Hi, I'm Dr. Ishfak, a specialty training in internal medicine. You're watching the Medical Forum. Hello guys, it's Ishfak. We've we couldn't discuss some questions from the cardiovascular system, no? These are the single best answer questions from the cardiovascular system module. So let's quickly go through them. A colleague refers a 44-year-old obese man. Okay, so let me highlight the important points so that a colleague refers a 44-year-old obese man for further evaluation of what he referred to as a resistant hypertension. Okay, a resistant hypertension. The patient had been intolerant of two medications, enalapril and amlodipine, initiated by the referring physician, and came to your clinic only currently taking HCT 25 milligrams daily, which he admitted that he forgot to take in the morning. He also tells you that whenever he sees a doctor, his blood pressure goes up. He is currently working in a hotel trade and has no control over what he eats. He drinks moderate amount of alcohol and smokes 5 to 6 cigarettes per day. He goes to the gym every day and claims that he is fit and healthy. On direct questioning, he admitted that he had not checked his blood sugar, lipids during 1 year. Examination revealed a BMI of 30. Pulse is 88 regular, blood pressures are 180 by 110, and this was in both hands in seated position. Examination of the rest of the cardiovascular system is unremarkable. Fundi shows grade 2 of hypertensive retinopathy changes. Does he fit the diagnosis of resistant hypertension? Now, what is resistant hypertension? He should be on 3 antihypertensives, out of which two should be ACE inhibitors or ARBs with a calcium channel blocker on maximal doses with a thiazide diuretic. But here the history says that he has been intolerant and currently only taking HCT. So definitely he's not having a history of resistant hypertension. So so yes, he has. So does he fit into the diagnosis of resistant hypertension? No. So it could be this or this. So why? As he must be having refractory BP on 3 antihypertensives, which must include a thiazide at optimal doses. So the answer should be E. Okay. Which of the following is least likely to help to reduce his cardiovascular risk? Reducing weight, it will help. High salt intake, no. Stopping alcohol consumption, yes. Usage of 3 antihypertensives, um, if it controls the blood pressure adequately, then yes. Regular exercises, yes. So the least likely is a high salt intake. The answer is B. Next question. A 13-year-old boy had a syncopal episode followed by generalized jerking of all his limbs while having a dental filling. He was nervous about the procedure when he was assessed at the ETU. His blood pressure was 140 by 80. Saturations are okay. ECG showed a normal sinus rhythm. What is the likely diagnosis? So this boy had been already nervous about the procedure, and while having a dental filling, possibly he would have felt so much of pain, and that pain and the emotional anxiety could have triggered a syncope, but that syncope can be associated with some jerky movements for very short period. So that is a vasovagal syncope. It is also called as a neurocardiogenically Syncope, a neurocardiogenic syncope. Carotid sinus hypersensitivity is that you have to press on the carotid sinuses like when giving carotid body massages, but that does not happen when you're doing a dental filling, no. So this is out of the option, out. And it is definitely not a generalized tonic-clonic seizure because um, when he was assessed he had been okay, no. There was no mention of any post-ictal drowsiness, so the likely answer is a vasovagal syncope or a neurocardiogenic syncope. The next question. A 70-year-old woman has a history of palpitations for 4 months. An ECG at that time showed a AF. So she was given digoxin, diuretics, aspirin. She now presents with two short-lived episodes of altered sensations in the left face, left arm, left leg. She had intermittent dysphagia as well. There is poor coordination of the left hand. Echo NCCT brain were normal. What is the most appropriate next step? No action, clopidogrel, starting warfarin, starting steroids, and carotid endarterectomy. Okay, so what has happened here? So likely this is a stroke. Maybe that is stroke would not have been manifested in the NCCT brain. Probably it would have been done earlier. So this is clinically a stroke. So the main thing what we have to notice is that this lady had a Chadwick score of 2 because she's the age is between less than 75 and more than 60, and she's a female. He's a female, no. So now what happened is there is evidence of a stroke. So this evidence of a stroke gives additional 2 points, and this 2 points makes it 4. So definitely we should start for warfarin. So answer is C. Steroids, no. Clopidogrel, well, anyways, he should be on one antiplatelet, so he's already on aspirin. So adding clopidogrel has no evidence. No action is not the obvious thing. Steroids, no place. Carotid endarterectomy, we don't know. No, they have not given what is the carotid Doppler, so we should not comment on that. Next question. A 79-year-old female presented with a history of recurrent falls. TLOC. On examination, no neurological signs. Blood pressures are 110 by 90. Pulse is 75. On auscultation, there was a systolic murmur in the aortic area which radiates to the neck. Which of the following investigations would help in a diagnosis? So this is basically clinically a left ventricular outflow tract obstruction leading to these symptoms. So definitely he needs a echo. 75-year-old, next question. 75-year-old woman who has recurrent angina on GTN spray, ecosprin, atova, and enalapril, and verapamil came to the clinic. On examination, her BP is still high, pulse rate is 60, good target. To prevent the above problem, what is your appropriate next management? So basically, this is a patient coming with recurrent angina. Now that is the problem. So they are asking how to optimize his drugs in terms of curtailing his angina. In terms of anti-anginals, verapamil is not that of a good drug, but amlodipine is not at all suitable for angina purpose. Better change this answer to diltiazem. Diltiazem. Change this answer to diltiazem. So changing verapamil to diltiazem is the most rational option because enalapril to captopril does not make any difference. Uh, Adding a beta blocker. Why add a beta blocker? Because she's already on a calcium channel blocker. The rate is already controlled. Give daily oral GTN. Well, she is already on a GTN spray. Giving oral GTN can try, but that is not the first thing to be done. Reassure the parent. Before reassuring the parent, you need to make a patient, you need to make sure that you correct uh, what can be optimized. So verapamil is not that suitable for patient with recurrent angina. So diltiazem is the best. So answer should be B. Kindly change this answer amlodipine to diltiazem so it makes sense. Next question. A 45-year-old man presents with a recurrent episode of left-sided chest pain on exertion. What is the next best step of investigation? So basically, this patient is having a history of recurrent chest pain on exertion only. So the next best step is definitely you need to go for an ECG first. ECG. That will be number 1. 8. Question number 8. 59-year-old male with hypertension and heart failure has breathlessness on exertion. Pulse rate is 80, blood pressure is 110 by 80. He is on furosemide and captopril. What is the next best drug? So basically there is heart failure. So he's on Lasix and an ACE inhibitor. What he needs is a beta blocker to reduce this. So what? Atenolol or metoprolol? Both are beta 1 selective agents, but metoprolol is having a short half-life. Now, in a patient who has this low blood pressure, rather than giving a long half-life drug, it's better to give a short half-life drug because the action is shorter and we can try to achieve lower heart rate. Only difference is we give atenolol as a once daily dose and this we give as a twice daily dose. Uh, so we can try with metoprolol. So metoprolol should be the answer. Next question. 64-year-old man comes with severe acute tearing central chest pain radiating to the left arm and back associated with sweating and vomiting. Well, the history is quite clear. His blood pressure on his right arm is 140 by 80. On examination, he has an AR murmur. So when you have this sort of a history with an AR murmur, always exclude aortic dissection. Aortic dissection, okay, that is most important because the moment you give thrombolysis or you give enoxaparin, he will eventually die. So the first thing, what is the next best step before ECG? Check blood pressure discrepancy in both arms. Check blood pressure discrepancy in both arms, and if you have a discrepancy, definitely you should go with a echocardiography. Okay, question number 10. Patient presents with recurrent left-sided chest pain on exertion. Resting ECG is normal. So what is the next step in the management? If the resting ECG is normal, either you can do a 6-minute walking in ECG or you can directly go for a exercise treadmill test or what you call as a exercise ECG. So that is the next step before arranging anything else. Question number 11. A 60-year-old diabetic male presents to the clinic. He takes metformin 850 TDS. He takes a thiazide diuretic. He takes ecosprin. He has had previous MI but is currently asymptomatic. So he is taking ecosprin as a secondary prevention. His BMI is 33 and blood pressures are towards the higher side. His total cholesterol was normal. Which of the following needs to be added? So he had MI previously, but now he is having a high BMI. He's a diabetic. He's over 40. So his blood pressures are also towards the higher side. So according to the evidence, he needs to be on statins. He needs to be on statins to reduce the atherosclerotic AS, atherosclerotic cardiovascular disease reduction. So he should be on a high dose, intensity, high intensity statins. So at least 40 milligrams and above. So ramipril, well, that will be good. But currently, to reduce his atherosclerotic cardiovascular disease, to choose one option, atava is the most important thing. Clopidogrel, he's already on icosprin. There's no indication for a dual antiplatelet. Nicorandil, they are second line agents. Orlistat is the second line thing. What you have to think after cardiovascular mortality reduction. Orlistat you can think to reduce his BMI in regard of his nutrition, but this is not the thing what we need to do first. But Atova, he needs to be on Atova because he's having a previous history of MI, so he has to be on high intensity statins. So these are the SBAs, and I'm sure these were easy. Uh, so these are the questions you will get. These sort of questions are the ones which you might get in your ERPM as well. So just do your basics, think simple, and that's all what you need to do. And thank you so much.